Partners at the University of Colorado School of Medicine. I'm also a developmental pediatrician in the section of developmental pediatrics, which includes JFK Partners. JFK Partners in the Colorado Title V MCH program collaboratively present a quarterly educational series to address the current Colorado Title V MCH priorities and emerging issues. This series is intended to expand the capacity of the maternal and child health workforce and related systems to better serve infants, children, youth, including those with special healthcare needs and their families. Feel free to type questions or comments in the chat at any time. We will monitor them, and ideally we will go through them in our discussion at the end. If something needs to be answered immediately, Dr. Ann Reynolds will be monitoring the chat, and she will we could address that issue right then and there. Please be sure to mute your microphone so we don't hear background noise. We're recording today's event and we'll archive it in the JFK Partners website along with the other webinars in this series. We have already posted the handout for today on this page, so you are welcome to print or save it for future reference. Following the webinar, you'll receive a link requesting an evaluation. You may also request a certificate of attendance. This is Autism Acceptance Month. So every April, we have a topic on autism. And so today, our topic is improving access to services to identify and manage children with autism spectrum disorder and other developmental disabilities. So I want to introduce you to the other speakers. We all work very closely together on this project. Dr. Ann Reynolds, she's a developmental pediatrician in the section of developmental pediatrics in the Department of Pediatrics. Rebecca Wilson, she's our psychologist, also section of developmental pediatrics within the Department of Peds. Richard Bowles, he's actually in the section of, his primary section is nutrition, but he also works with developmental pediatrics and JFK Partners, and he's our associate director of research. So he straddles a couple of sections. And Liz Cohn, she's a psychologist, and she also is in the section of developmental peds. And Sarah Maddie is a social worker, and she is also, we're all, except for Richard, our main association is developmental pediatrics. So next slide, please. We have no disclosures. So today we're going to define barriers for obtaining comprehensive diagnostic assessments for children with complex developmental and behavioral profiles. Hopefully we'll describe our different pathways to increase capacity of primary care providers to manage kids with ASD and DD. We'll introduce our intake team, enhance intake processes and coordination of services, and we'll also demonstrate and understand, we hope that you'll be able to demonstrate an understanding of the purpose and practice of ECHO, which is extension of community health outcomes to support the management of children with ASD and DD within the context of their medical home. So as I think everybody is aware, the prevalence of autism continues to increase. In 2020, it was 1 in 54 children. It's a little less in Colorado. I think it's 1 in 72 or close to that, but it continues to increase. Next slide. This is not just a problem, obviously, in Colorado, as we saw from the map before. It's a national problem. And there's increasing developmental disabilities, which includes autism spectrum disorder. Right now, the likelihood of a person having a developmental disability is about 18%. 1 in 6 children between the ages of 2 and 8 years have developmental, behavioral, and/or mental health problems. And as a group, these are the type of kids we are manage. And there actually is a shortage of developmental behavioral pediatricians. So Colorado is unique in that it's a bisection of the state by the Front Range and the Rocky Mountains. There's very few providers in more remote, rural and frontier areas. And rather than having to travel to a tertiary care center, we want to think about how we could provide care to them closer to home, because travel's difficult, it's expensive, and especially in the winter, it could be almost impossible. Next slide, please. So 87% of Colorado's population lives in the metro area, and but 6% of children live in rural and frontier rural areas, and 3% live in frontier regions. And overall, 33% of children and youth with special health care needs can't get timely health care provider appointments. 38% can't obtain transportation, or the office is too far away. And there's racial disparities in that 42% of Hispanic children are without a medical home. So there's more demand than there's people to meet the demand. So we really tried to put together a program where we could expand capacity in the community, because we can't see every child with a developmental problem, but we could support primary care providers to feel more comfortable doing more with our support and technical assistance. Next slide, please. So just to drive home the point, in terms of developmental behavioral pediatricians, and they're not the only individuals who manage kids with disabilities, but they're the prime people and psychologists who work with them. There has been only 904 physicians certified. However, 198 have had their certification lapsed, a lot because of retirement. And it is an aging specialty. But currently in the whole United States, there's 706 board certified developmental behavioral pediatricians. In the Rocky Mountain area, there's none in Wyoming, none in North Dakota, one in both Idaho, South Dakota, 2 in New Mexico, 2 in Utah, 3 in Nevada. At one point we had 14. In 2019, there was 7. So that makes, for Colorado, there was 1.1 developmental behavioral pediatrician for every 100,000 children. So we have a lot of challenges and there's a lot of needs. And so we try to be creative to meet the needs of Colorado. So this project is focused in Colorado. We have long waiting lists that we try to address. I just talked about the need for providers. There's open MD positions throughout the whole country, because it's hard to fill these slots because they're not enough. We particularly had an intake questionnaire that didn't really provide us with all the information we needed, and yet we didn't want it to be too cumbersome for families as well. We decided that we needed to reevaluate our models of care to be more efficient and cost effective. And before, a plan of care wasn't developed until after the assessment was complete. And as you will see, with our new intake model, we do support families even before they walk through the door. And when we used to get referrals from primary care docs, the referral would say diagnose and treat. That was it. They wouldn't talk about what the problem was, what they wanted us to evaluate. And so that sometimes kids weren't matched with the right type of clinic because we just didn't have the information we needed. Okay, next slide. So am I doing this slide? Okay, sorry. So we have an 8 paths for coordinated care. The first path, number 1, is a coordinated intake and our initial telehealth assessment. The second one is our clinic model. The third pathway is telehealth. The fourth is ECHO. The fifth is STAT training, which is a secondary autism screener. The sixth is e-consult. The 7 is working with the Pediatric Care Network, PCN, and the 8th is outreach to rural PCPs. So what we're going to do is peel that off. So Rebecca, do you want to talk about this?
So I'll take it from here.
I'm sorry, Sarah.
That's okay.
I don't have who's saying what. I apologize.
So just so you know, this is our previous state. And as you can see, this very chaotic screen of all of our specialties that do care for children with autism or developmental delays. So we're going to go to the next slide, which we have worked really hard on as far as getting things cleaned up. This is a little bit clearer, identifying, like Dr. Friedman said, we specifically have coordinated care prior to the child coming into the doors of Children's Hospital or Developmental Pediatrics. So we'll go into more detail in just a second. And this pathway, we have now introduced a team of people helping with the referral process. And that resource team includes a referral coordinator, health navigator, an RN care coordinator, myself and LCSW, and a care coordinator who is also getting their social work degree. So we have some robust clinical team to help really identify where these kiddos need to be within the Children's Hospital or the community. Next is that we have implemented a new referral process for our PCPs, including identifying the reason for a referral to Children's Hospital and identifying it a little bit clearer. We provide pre and post evaluation, so we can provide supports with OT, PT, speech, whatever is needed prior to an evaluation after interviewing the families and getting some more information. Also providing resources if they already have an autism diagnosis, so we don't have to have them sit on a wait list if they're not needed. We provided new tools for pediatricians and families, including a MyChart questionnaire, which is a lot easier to fill out than printing, writing it in, and then sending it in via the computer, because families are having a hard time with those types of getting the paperwork back to us. So it's more efficient and we can get them on the list sooner. And then we now introduce telehealth visits, including with social workers as well. And we're doing education as a social work team for primary care through ECHO and PCN.
I'm going to talk about this slide real quick because I'm very passionate about the way we've been able to really improve the efficiency of our care with our initial assessment model. And before COVID and before telehealth, we implemented this model, which was designed to first provide a short initial assessment to make sure that we kind of right fit our clinical care for kids. And then when we had to pivot to telehealth because of COVID, we continued that model. And overall, what we have found is about 30% of our kids who go through this model need no further follow-up, and all they need is that initial assessment. What we've found, and that this color pulse chart on the side shows, is that there is an age group we've identified that really benefit from this approach. And that's because this is the age in which kind of dual diagnosis starts playing more of a role in behavior. And so sometimes we can identify that there can be better care in other settings because of this other kind of comorbid psychiatric condition that we can send on to a better fit for care.
Can I just add to that, Rebecca? So part of this, especially for that age group, is to get away from what used to be kind of going on in the community, which was that diagnose and treat referral. And so we'd get a lot of kids who maybe had learning concerns, but were not at risk for intellectual disability or autism or a true developmental delay, which is what our specialty is. And so this is our way of kind of weeding out like the 9-year-old who is there. And I had this happen to me a couple of years ago, who came in and he's like, I'm here because of my dyslexia. And I was like, Well, great, but that's not what we do at all. So instead of doing a full, evaluation with this kid, it was a 90-minute appointment where I could get a quick assessment of what his needs were, and then triage him to another department in children's where he could have that looked at more closely.
Okay, so pathway 2 has been to improve our model of care and make us more efficient. So the first thing we did was go through templates and make sure that we were optimizing template utilization. We initiated a project called a nursing bookend, which means that we have RNs partnering with medical providers to pre-chart during the visit and then potentially work with the family on anything that needs extra work after the visit's over. And that's been very helpful. It's made our medical providers more efficient, but the nursing staff has really enjoyed it and has felt more like part of the team. So that's been great. And so that we've been able to increase the number of patients that providers can see per clinic session with that model. We've also expanded our clinic model by adding a genetic counselor and social work visits. And task shifting so that people are all working at top of scope. And then the initial assessment model, as Rebecca was talking about, and then the PCN model, which Liz will talk about later on in this presentation. So I think so for telehealth, Children's did an amazing job at the beginning of the pandemic. We were having about 5,000 telehealth visits per year. And within about a month to 6 weeks, we were having about 5,000 telehealth visits per week. So that was quite a heavy lift and a big adjustment for everyone. And so, but we were able to embrace that and go with it because we'd already started doing a little bit of that with our initial assessments. And this is particularly helpful and will continue to be helpful for kids that are coming from, more rural and remote areas of the state. The in-home telehealth, as Rebecca was talking about, also is nice because for families who have a child who just doesn't do well with coming through the busy hospital and sitting in a clinic office while we talk about them. So the in-home telehealth has been great. The psychologists have also had the opportunity to observe children in their home environment, which has been particularly useful for us. Not only because when they come to the clinic, we're all masked and shielded at this point, but also just to see the child in their own environment and have the parents participate in the evaluation by interacting with their child so that the psychologist can observe them. And then at this point, about 65% of our visits are telehealth because we only have limited space in the clinic due to social distancing, but part of it is because it works very well. We're also using it for our feedback visits.
So the point about that circle, those circles, is the very significant change that we've been able to leverage with telehealth from 2018 to the present, where we were doing literally 1 or 2 telehealth assessments a week. And now, like Dr. Reynolds said, we're doing 65% of all of our visits are telehealth.
Which at this point is probably over 100 visits a week. And I think these are my slides. I'm sorry. I'll just go ahead. But I think the telehealth appointment for the initial assessment is very helpful because, and this can be done by psychologists, but also by social work, because they can provide resources, referrals, therapies, other, referral to other services at Children's in that initial assessment, referral to the community. And then it can be done prior to an in-person interdisciplinary assessment.
Okay, thank you. So I'm going to talk about the fourth pathway, which involves our partnership with ECHO. As mentioned before, this is the extension for community health outcomes in Colorado. For those who may not know, ECHO is a nonprofit dedicated to increasing everyone's capacity to manage complex health issues using technology, bringing professionals together from all various disciplines to share knowledge and experiences and viewpoints with one another. And to date, we've had 6 cohorts of providers who've been trained on core concepts for the screening, diagnosis, and management of children with ASD. Specifically, 109 providers across 22 counties have received training, which includes 65% of patients who are underserved, which really highlights the importance of this partnership, being able to reach many of the families who have been underserved for various reasons, including being low income with few resources or geographically separated from urban centers, which is one of the primary goals of this training process. So additionally, community of practice monthly case reviews have occurred, which has provided training and support for children and families with ASD. And in response to provider feedback, we're now providing a more intensive training for our next type of ECHO. And so specifically, we've redesigned our curriculum and the delivery, which now includes autism core concepts for primary care. There's a part 1 and a part 2 with 5 sessions in each of these series. It's still focused on the support for providers in screening, diagnosis, and management of patients with autism spectrum disorders and related developmental delays. Next slide. So this map of Colorado counties shows our current provider reach. As I mentioned, 22 counties and counting, including what is a nice equal mix of both urban and rural areas of the state. It's important, though, that we show that beyond these locations that are highlighted here, we know, however, that our program has reached families into neighboring counties, for example, during on-site visits to clinics. So, for example, we're able to reach families around the Gunnison area for those providers who may have come from the Montrose area. And so this is probably an underrepresentation, I think, of our actual reach so far. But this shows where our providers themselves have been from during the ECHO training. And as you can see from the map, briefly, just that, we still have work to do that we're aiming for. And so in the future, we're looking for expansion in terms of both the Northeast and the Southeast areas that we're hoping to reach. And hopefully we can really start to eliminate any of these kinds of pockets of reach. Okay, next slide. So for the ECHO series, we survey our providers across a number of different areas. And for today's talk, I wanted to highlight changes in some of the reported skill levels. And so here we show provider practice behaviors reported for before and after the ECHO training, which nicely shows improvement across all of them. To orient you to this, the way to understand the scores on these particular practice behaviors are represented by the diamonds there on the left, and then the after improvement are represented within the numbers in the circles. The different colors just show that we've collapsed all of our previous cohorts, which are in the dark blue, and then for our most recent series, we have that in the gray. I think the point to show that with this graph, though, is that we've shown improvement across a number of different areas, including the discussion of ASD diagnostics criteria across all ages, the evaluation of behavioral problems and the implementation of behavioral management strategies, the management of common comorbid challenges, including sleep, anxiety, and ADHD, as well as medication management. And so again, we've seen improvements in all of these different areas. Next slide. And so in addition to our quantitative metrics just mentioned, we wanted to show some of the qualitative feedback as well from our trained providers. And so these are actual quotes that have been given to us. And I think notably the providers who are more remote really appreciate the support from children's as well as the opportunity to network with other providers who may be within that area. And they also report benefits from training that's been received from a multidisciplinary team with really a range of topics from foundational ASD knowledge to really specific behavioral strategies. So there's quite a spectrum, I think, in terms of the range of this kind of training for providers. Next slide. So when asked about the changes that these providers are going to make after having had this training, they talk about reporting, future practice to include routine screening, routine follow-up, more direct communication with families about ASD concerns and diagnosis, and really an increased focus on early diagnosis as well as referrals. And I think that lastly, providers are reporting greater confidence across screening, diagnosis, and management, which really positively impacts their independence and their ability to start helping children sooner than the past.
So another area where we've been able to train and really mentor primary care providers is we've provided 2 trainings on the STAT, which is a secondary screener for autism in toddlers. So it's typically meant to be between 2 and 3, but you can use it often from 1 to 4. So we had an initial training with just an online tutorial and then followed by an in-person conference to cover all the other areas that we felt you needed to know in addition to doing the screening. And so that was just our pilot model. We had 11 providers in November 2018. And then we had a 1.5 day meant to be in person, but converted to virtual pretty successfully because of COVID. With training on the STAT for 1.5 days, where we really went into, subtle nuances of the screening, and also people could ask questions and get feedback. And so we're planning a 3rd training this summer, and we're going to add booster sessions so that people can ask questions after they've actually used the STAT. And we've had a lot of participants send us patients, and we've tried to expedite those evaluations so that we can give them real-time feedback about what they found during the screening to hopefully improve their skills, so that if they see a child where it's very clear that they have autism, they can go ahead and make the diagnosis using DSM-5 criteria and get them into services more quickly.
Can I just jump in and add one more thing? What we found about being able to provide a virtual format for STAT training is it makes this training a lot more accessible for our rural and remote partners, which really aligns with our overall goals of this project, so that they really can access the training, be in clinic, get into the training and go back to clinic. And so it really has been really a nice benefit of what was a forced pivot to a virtual format.
And I just want to add one more thing. We were very lucky to have our 2nd and our 3rd upcoming training being done by the person who actually developed the STAT. So she's the expert in how to do it. And so we were going to pay for her to come here and stay here to give the training. And she had never done a telehealth before, but it worked great. Very well received. Okay, our 6th pathway is e-consultations. Actually, they were supported initially through the medical school, the University of Colorado School of Medicine, and they started rolling out in the child health clinic at Children's Hospital Colorado in June of 19. And at that point, there was a very small subset of PCPs who were asking questions. Then they opened it, they started doing it with a small group of physicians in the Pediatric Care Network, the PCN network that Liz is going to talk about. And our first e-consult was in July of 2019. And at this point, all of the Peds Connect practices, and what those are pediatric practices in the community that have access to our electronic medical record, EPIC. So they actually see our notes, we see their notes, and they could, take orders. And so what they do is they put in an EPIC question, a referral, a consult question into EPIC, and then we answer them. And this is to allow them to be able to do more and not necessarily have to refer. Some kids definitely do need to be seen, and some questions are really just referral questions, but we have done 77, and those we just send back to the PCP and tell them, that we'll get them in for an appointment or how to refer. But we've done 77 e-consults to date. And these are management problems. I have a child with X, Y, or Z. What could I do before he gets to see you? Or what could I do, period? And they do that with multiple specialties at Children's Hospital. And we actually bill for it. Initially, we don't get a lot of money, but we do bill for it. Initially, the medical school was supplementing it. And now HICPUF, I think, has or will be providing codes for billing for this. Okay, next section. Next.
Okay, that's me. So I'm going to talk a little bit about our PCN model, which is our 7th pathway in the overarching 8-pathway model. But this is a program that we put together a couple years ago now, where we work in collaboration with the Pediatric Care Network, which is a group of pediatricians' offices across Colorado that are affiliated with the hospital. And so we were approached by the PCN network asking for some support related to autism management within PCP offices, and also just advanced trainings related to diagnosis and identification of autism more generally. So the program, when it was first developed, involved a psychologist going out to the pediatricians' offices and providing personalized trainings related to diagnostic criteria for autism, how to identify red flags for autism across the lifespan, talking to families about autism, meaning being willing to say the A word out loud in the office, and then training them specifically in how to do an autism-focused developmental history, which is one of the core components of our evaluations that we do in clinic. So after the pediatrician's office goes through that training, they're then provided with a template for this developmental history and support, meaning kind of ongoing consultation with them about how they're doing their histories. And so once they complete the history in the office, in the PCP's office with the family, they then refer their kid to Children's. And the idea would be that they would get an expedited evaluation with us, because so much of the kind of prep work had been done in the pediatrician's office. So we would complete the evaluation, so to speak. And following the evaluation at Children's, we would give much more personalized feedback to the PCP about the referral they sent in. So thank you so much for sending so-and-so to see us. Just like you noted in the developmental history, I also saw really reduced eye contact. I saw limited use of gestures. And I listened to the kid talk about black holes for about 25 minutes, right? And we can say, great job. I saw a lot of the same things that you saw that caused you to make this referral. Or we could provide some feedback that may look a little different. Yes, I saw reduced eye contact, and yes, she was hesitant to speak with me, but after spending extended time with her, really this looks like an intersection of anxiety and ADHD. And so giving them some feedback about how we kind of make those differential diagnoses. And of course, then the patient after the full evaluation would be triaged to appropriate next steps, either within our department or out in the community. And Sarah Maddie and our next steps team or family navigation team often meets with the family to kind of support them through that process. So we have collected some data on the program overall. And really, we're getting pretty good report. We're seeing that over 90% of the participants are saying that they have improved knowledge of how to identify ASD, improved knowledge of how to manage kids and their families with ASD in their office, and also that their confidence has improved. So they feel more confident identifying red flags for autism. They feel more confident speaking to families about autism, which is huge. And they feel more confident that they actually kind of know what some of the next steps may be when their families are in their office asking for support related to this diagnosis. The other thing that we found as kind of a byproduct of this program is that, and we can talk about this a little bit more because it's a double-edged sword here. But after getting these advanced trainings related to autism, we're seeing that there was a significant increase in reported by the pediatricians saying that they have concern for autism now much more frequently when they're meeting families in their office, which means that after these trainings, maybe they're beginning to see autism through kind of a different lens. Maybe the 10-year-old that didn't have kind of the big classic red flag symptoms when they were 2 or 3, but maybe has had some social troubles or has had some difficulty in school, they're now beginning to think, oh my gosh, maybe I should be thinking about autism, and that really wasn't kind of in their mind before. We're also seeing an increase in referrals to developmental peds, another double-edged sword. But the other thing, and this is one of the points I'm most excited about, is that the pediatricians are reporting a significant increase in how often they're consulting with one of us in developmental pediatrics, which really is the point of this model. It's to kind of encourage our community providers to feel like we are true partners in the evaluation process. And so, you know, it means a lot of emails and a lot of in baskets and a lot of calls after a workday. But right now, it's just truly very exciting to be in such close contact with a lot of our community pediatricians because they feel like we're accessible. And I think our reputation still often in the community is that we refer to children's for an eval and then we don't know what happens, or it's so hard to get in touch with people there. And we want to break that down and really be more accessible. So that's a big part of this program as well. So we've also gotten some great just qualitative report about, you know, the things that they've appreciated about the program. This was mostly about the education that was provided out in the PCP's office, but they've really enjoyed those education sessions. And this other larger comment here on my right-hand side, I don't even know what's happening with the Zoom, but you know, whatever, the longer one that's on your screen really talks about too, I never would have thought about autism before, but now I'm beginning to think about this, and other people in the community might have said no to this, but because of the training, now I'm beginning to think about it a different way. So just cool stuff that's happening, I think, in the pediatrician's office as a result. So with the year 2020, we had to do a lot of updates, as everybody did, kind of in response to COVID, but we also made some additional adjustments to the program based on the feedback that we were getting from the pediatricians who had been participating in the program. So the 3 big updates here are one, that we created a fast access pathway to a resource-only appointment, and I'll tell you about that in a minute. And as we've kind of touched on in previous pathways that Anne and I think Anne and Richard were talking about, we've created a telehealth hybrid model, and then we've also created an ECHO training that's specific for the PCN providers. Oh, my animation, yes. So the expedited access really looks like this, that kind of the old school way that we were doing our evaluations is that the PCPs would refer the kid in for a diagnostic evaluation, and then following the diagnostic evaluation, they would have access to meet with our family navigation team and talk about resources. So what we're doing now for just the pediatricians that have been through the PCN training is that we're creating this alternative pathway where they can refer directly to the next steps appointment. And this is really to help pediatricians feel like, hey, if you have a kid in your office who you feel like has autism spectrum disorder and you are pretty sure about it, please do not put them on our wait list for a comprehensive diagnostic evaluation when you have the information to confirm the diagnosis on your own. And I think a lot of pediatricians have been hesitant to do that because they're like, well, we still want them to kind of get the resources that maybe Children's has to offer. And so as part of kind of encouraging more independent confidence in the pediatrician's office, we've said, if you make the diagnosis, we will fast track them to a next steps appointment and still support the family in getting those resource needs met, talking about insurance, talking about the other options that might be needed for support. The other case where this is really helpful is for those pediatricians who may get a new patient in their office who's moved from another state, who comes with a diagnosis of autism, right? So what we want to move away from is, no, they do not need to go through a diagnostic eval at Children's, right? If they already have the diagnosis of autism, and we are still here to support you. So this is something that we rolled out right around April of last year. And so it's a newer service. And it came out right just when the pandemic hit as well. So we're still kind of gathering data on how often this is used, but we're really trying to push it out pretty strongly now.
Also, we also have that expedited referral for the PCPs who participate in our community of practice,
Right.
and so that they can feel more comfortable with diagnosis and management within their medical home. I would say that sometimes the PCPs have told us, you know, I really knew the child had autism, but I didn't know what to do once I made the diagnosis. And so now we're trying to give them those skills so that they can feel more confident.
Yes. And even before that, some of the feedback that I would get from PCPs when I went out to do the training was, I would walk out of the room and say to my nurse, that kid has autism for sure, but would not say it to the family, right? So part of this is also supporting that we can say this word out loud, because we are helping you feel more confident that if this is the case, firstly, it doesn't have to be terrible news. And secondly, we have a plan for this and we'll help you work through this plan. So the PCN program has also done its own telehealth hybrid model. And this is just data from April through December of 2020. At that point, we had done about 60 evaluations through a telehealth hybrid model. Our average wait time, 6 months and going up. And that's largely because, firstly, we are getting more referrals through this program, but also because of specific safety precautions and procedures that are in place in the hospital, like Anne alluded to before. We have limited capacity for seeing kids in clinic. So a lot of times it means that we're starting kids on a telehealth with a telehealth evaluation, and then determining if they need to come into clinic, and that might be several weeks later. What we are seeing is that of all these kids referred to us through this pathway, through the PCN pathway, that about 70% are diagnosed with autism, which is a pretty high kind of confirmatory result, right? And this sounds like a nice statistic, because what it suggests is, oh, the kids that the PCPs are identifying actually do go on to have a diagnosis of autism most of the time. The thing that's a little complicated with this statistic is that it doesn't mean that the other 30% were bad referrals, right? And a lot of times, especially with our older kids, the differential is so complex that it actually is a really good question to ask if they may have autism, but it might not have been the final result. And the flip side to that is that sometimes with some of the PCPs that I've been working with for 2 years, sometimes the worst referral is the kid that's a slam dunk for autism, right? Because what my feedback then to that PCP is, you know this, right? You wrote it in your developmental history. You clearly thought that the kid had autism. How can I support you in making that diagnostic call in your office so that we're not wasting time putting them on this wait list? And then our statistics are similar to kind of the department as a whole, that about 30% of these referrals through the PCN network that we're doing a telehealth hybrid model eval for, about 30% can be completed in one telehealth appointment, meaning that they don't have to come into clinic. Another very complicated statistic, because a lot of times we just have to meet the family where they're at. And sometimes that means we're bringing kids to clinic for a full diagnostic evaluation, even if myself as the clinician knew the diagnosis after a telehealth call. We really are here to serve the family in the way that's most comfortable to them. And so sometimes that means we're doing full evals.
So I just want to, we're getting a lot of chat messages, but I did want to clarify this right now. The fast track for evals, yes, we do want providers to give us more than just diagnose and treat, but we're only providing the fast track to those who are actively engaged in learning, because we know where they are in the process. And we quite frankly, if we did that for everybody, then we would be right back where we were with you know, a ton of referrals and then trying to sort out how to give feedback.
Yeah, so the point of the expedited pathway is that these PCPs have gone through specific training so that they're packaging, and really what we're asking them to do is quite a heavy lift. They are having a 45 to 60-minute additional appointment in the PCP's office with the family to complete the developmental history. So, right, this is kind of the carrot or the payoff that we're offering for doing that extra work in the medical home. And then, right, gosh, when did we do this? Summer of 2020, we launched the PCN Advanced Autism Echo series. So again, using our partnership with Echo that Richard spoke about before, we created a specific training that was just for those PCN practices who had already gone through the first educational series. So I had been out to the practice to train them. But when I was out in the practice and when they started kind of referring their kids to us, we saw more questions come up, right? So they wanted more information about behavior management, definitely wanted more information about medication management, definitely wanted more education about, what do you mean I have to place a referral for genetic counseling? What does that even mean? How do I talk to families about that? Concerns about sleep, toileting, other specific behavioral issues that really, are not completely in my purview as a psychologist. So what we did is put together a interdisciplinary team of experts and created an advanced echo training series where we covered these topics just for those PCPs that had been through the initial PCN training. Again, allowing us to talk about things at kind of a higher level, allowing them to come in with very specific questions. And it also made a great kind of platform for us to discuss patients that had been referred through the PCN pathway because we had, you know, at that point seen a lot of them in our clinic. And that's it for me. Thanks so much.
This is mine, and it's mine because I'm so passionate about this. We've been able to develop partnerships with a number of practices in rural and remote communities. You can see here that most of these partnerships have been on the Western Slope. And in part that is because these have been practices that have this long-standing outreach position with Children's Hospital Colorado. So they were kind of the low-hanging fruit, if you will, for practices who were really ready to engage with us for our outreach clinics. It's important to emphasize here, we don't just go out to these outreach clinics and do at the clinic what we would have done at Children's. What we're really trying to do is partner with PCPs to enhance their ability to identify kids with autism. So we really screen the patients we see in outreach for either ones that are useful to partner with the primary care clinicians about, or families that really cannot travel for either very significant financial reasons or because the kids are so impaired they really cannot be transported. So the red stars are the ones that we are actively partnered with and have done clinics with, and those are in Edwards, primary care in Rifle, Durango, and in just a couple of weeks we're going out to Montrose. And then we are actively developing clinics for Glenwood Springs and for Pagosa Springs, and we anticipate that we'll go out to those clinics within the next 6 months. I also want to talk a little bit about the big picture. Now, we've all been talking about all these different pathways and all this different work we're doing. And I just want to bring it back to an overview real quick. So this was our previous model, the role of the PCP, what our administration assistants did, who was our amazing team, and then our developmental pediatricians and nurse practitioners, our psychologists, and the role of the family. And what we did is we looked at our clinic and said, where can we change things? What could we change to improve and make our processes more efficient? So these were the areas we kind of identified as, could we task shift this a little bit? And what we did, and what we hope to continue to do, we're still in the process of this, definitely a work in progress, is improving the referrals we're getting from PCPs, helping them to have that discussion about autism, as Liz talked about, conducting more of a developmental history than we were getting previously, and just take care of some of the basic medical workup that our physicians would want to have done before they see the patients. And then, as Sarah Maddie presented, a coordinated and much more robust intake model so we can get resources right at the very beginning back to families and refer them out if they really don't need to be on our wait list at all. That positions our developmental pediatricians to really provide their advanced and specialty workup of patients. And so they see the patients that are a good fit for our developmental behavioral pediatricians, because they are, as Sandy presented, such a rare resource. And they really can look at our kids from a different lens. We have also shifted this very important adaptive interview to the psychologists so that we can keep our MDs at top of scope. And then the parents have been able to play a more robust role in our entire intake process through that MyChart questionnaire that Sarah Maddie mentioned. And then the genetic counselor role, I mean, I just can't say how much that has really helped our overall efficiency, and again, placing our physicians back in the role of being a developmental behavioral physician rather than a genetic counselor.
I just wanted to add to that too, Rebecca. You know, and there was a question in the chat that I looked at briefly, kind of talking about moving away from this bad news diagnosis of autism. And kind of in that same thread, I think our efforts here are also part of the like destigmatizing process, right? So, you know, I often, with the PCPs that I work with, I'll often talk about the fact that, you know, autism hasn't been a rare condition in several decades, right? Since the beginning of the 2000s, I think is when the last time it was considered a rare condition. This is something that affects almost 2% of our population. So gone are the days when autism was a rare thing that we didn't know about and we had to refer to specialists and only specialists could handle it, right? I think there are presentations of autism, often ones that are complicated by other medical conditions or medical complications or significant mental health needs that really do need expertise. And we want to save our developmental behavioral pediatricians who have such specific training in that area to see those kids. But the big message here is that there are lots of people with autism in the world. And if we keep having this kind of, this is dating me too, but what I'll say is like this Voldemort idea, like that thing we don't speak of, right? We don't talk about it in the PCP's office. We just send you to Children's and they'll handle it. It adds to the stigma, right? And so part of what we're trying to do here is encourage, right, our partners in pediatrician's office, in other kind of care avenues, to feel like we can say this word out loud, right? Because it's not all bad news. And if it is autism, guess what? We have a plan for that. We can help you get there. We really need to have that attitude around this diagnosis. And I could talk about this forever, how awesome it is to get a diagnosis of autism in a lot of ways. But often I need to just temper myself, you know, and we want to meet families where they're at. But I think that is something that we are moving toward. And if we're not talking about it specifically the way I am right now, at least this kind of spreading out of care is a way that we're trying to kind of attack that stigma that exists out there by saying like, we've got this, right? As a community, we've got this, and we can partner together to help you move forward.
Sorry, having trouble unmuting. as everybody knows, that's often an issue for me. So what's changed? So we've had, this expanded education and partnerships with PCPs through the ECHO, PCN, and outreach clinics. It's been wonderful. I know that there was one comment from Heidi about, working with schools. One of the things so we review cases when we do these ECHO sessions. And one of the things we say is, well, why don't you, talk with the school, see how they're doing there. And that's really been wonderful. We had one provider in Edwards who was, struggling with how to manage kids on the spectrum. And she started working with the school. She found an OT in the community to work with. And now they actually have ABA providers in that area. And so I know there was a question too about Steamboat, La Junta, Salida. We would love to, we've worked with HCP on trying to find providers. We do have providers in Steamboat that Liz has started working with through PCN. I think we had a provider from La Junta, participate, but get the word out, encourage any primary care providers that And so it's not just physicians, it's nurse practitioners, PAs, people like that. So that has just been wonderful, and we all really enjoy it. It's been, we feel like we're for a lot of these providers now, we're just mentoring them rather than training them. So we do have our coordinated intake process, which has been a heavy lift. I know Sarah and Rebecca have worked tirelessly on that, and we're just getting it up and running, but we feel like it's going to be a much better service for families to have that intake process, have providers staff participating in the intake early in the process rather than after they're seen. We're doing a lot of upgrades to MyChart, which is our electronic medical record that is patient facing, on parents filling out questionnaires, which makes the providers more efficient and makes sure that the family is heard and get their questions answered. Our resource team, as Sarah spoke about, is amazing. We've added a social worker, genetic counselor, RN care coordinator, full-time health navigator, and for making improving quality of care and experience for families, we've added a child life specialist who's supporting kids with procedures. Her name's Hope. She's amazing. And we also have a genetic counselor as well. And then we're working on clinic models that we've already spoken about to improve efficiency as well, and then expansion of e-consult. So you can see we've been busy, but we still have a long way to go. we are not there yet, but we are, and we're hoping to continue to expand this, because if every child with asthma had to see the pulmonary specialist before they could start treatment, it would not be good. And so we really want primary care providers to feel much more comfortable with kids who have straightforward diagnoses or straightforward management, and where we can just provide mentorship and support, and then see the children whose diagnosis or management is more challenging.
And could we go back to one more to Anne's slide? I just wanted to make one comment about the coordinated intake. At the beginning, Sarah showed you the before and after for intake. So there were many people with concerns for autism may be referred to developmental peds. They may have been referred to the Pediatric Mental Health Institute or child psychiatry or special care clinic, or to primary care clinic at Children's, or speech OT PT. So what we do now is we have one point of entry. And so I just want to make it clear. So if when it actually lives within our section, but if somebody calls and we do an intake and said, you really should be in child psychiatry, we refer them there. Or if they have complex medical conditions and they really could benefit from special care clinic, we refer them there. So there's a unified referral process from all the different specialties that touch children with autism and their families. And that has been a very long process, and Rebecca and Sarah, I mean, we've had many people from all these different departments and sections work on this, but in our section, Rebecca, and actually for all of it, Rebecca and Sarah have been on the forefront of making a system that is more streamlined. So I just wanted to give kudos to you guys. Okay. So
Thanks, Andy. Let me just add one more thing about that. Appreciate it. It's really been a pleasure to do. And I know Sarah and I are proud of the advances we've made, but as Ann said, long ways to go. But what we found was that even families that worked within our system couldn't navigate Children's Hospital. So if families that work within our systems can't navigate it, how could we expect another family to navigate it? So we are passionate about this advance, and we really are very hopeful that this will be really a better entire experience for families.
Okay, and so the future. So as Ann and Rebecca just said, there's a lot to be done. We really are in the throes of trying to expand our outreach clinics. And we also are trying to broaden educational efforts for primary care providers to use ECHO. So we, the ECHO at Children's, they send out to invites to PCPs when we, right before an ECHO series, so people could join up. And if you haven't been on any of those invites, if you want to email any of us with your email address, we will make certain you're invited to upcoming sessions. And once you complete the series of, we do didactics and then case-based, HIPAA compliant case-based review, then you could join our community of practice, which is all just case reviews. So the people who have gone through ECHO, they come with complicated patients that they want a group discussion, not only with our team, but with all the other primary care providers, because we all learn from each other, including our team. So we learn from the primary care providers as well about things we may not have thought about. So it's a really nice working relationship. So we are expanding to Colorado Springs. We are going to have a developmental pediatrician and 2 psychologists actually located in Colorado Springs at the Children's Hospital, actually the outpatient, and then they're building a new therapy center there in Colorado Springs. And then, as was mentioned before, we really have a need for the east part of, in addition to more west and south, but the northeast and the southeast part of Colorado, we hope to be able to expand that our presence there as well. And we continue to work on improving our clinical efficiency. We could always do a better job of being more efficient, and but we are all passionate about giving better care to children and families with disabilities and supporting other people who see these kids too in their practices. And now I think we're opening up for questions.
Yeah, and so I know we've had quite a few as we've been going along, and if anybody wants to actually ask their question in person, that would be great. I think one of them from Anita was that who were providers who participated in ECHO in your area. If you want to give, ask us, we could tell us where your area is. We could give you information about providers. Probably offline, since that will be very individualized. And then, yeah, and we're very happy to give you information about the ECHO and STAT trainings. ECHO Colorado has our ECHO trainings there, but we can get you the contact so that people can sign up if they'd like to. Rochelle has made me realize that we've done so much diversity training this year that we need to do more with people with neurodiversity, and that the word management is offensive, and so we need to come up with a better term for that. We do work hard to engage in shared decision making with families, but management is a very medical term that we need to rethink. So thank you for that feedback.
Could I just mention one thing, Anne? A lot of the families we have seen when we've gone to regional clinics are Spanish-speaking families, and we have a Spanish-speaking psychologist. And a number of these families, we have two. Okay, and a number of these families are also undocumented. So we actually we go to the underserved and try to meet the needs of the community and try to provide what resources that these families could access. They can't, undocumented families can't access a lot of resources, but there's some things they can. So I just wanted to mention that.
Yeah, and there was also a question about resources in rural areas, and that's where our community of practice has been nice, because we get information from people who are out in the trenches. But I think that obviously, I mean, there are more and more resources every year, but we do have to, it does become more challenging in rural settings. But there are ABA providers in the Durango area, some I think in the Montrose Delta area, some in Grand Junction, some in Steamboat,
Edward.
Haven, yeah, Edwards. And then, you know, so we recognize that as an issue, and often we're doing the best we can. We also, with telehealth, are now doing our ABCs of behavior training for parents, and some early start Denver model training with parents through telehealth, which is, I mean, telehealth has been like possibly the only silver lining, other than spending more time with your family, which isn't always a silver lining of COVID. But so that's great. And I think, yeah, and if anybody has names of providers in some of the areas you asked about, we would love to hear about that.
And I just want to mention one more thing, Anne, in reference to the resources. During the ECHO, Sarah provides resources for the different communities that the participants are in. We post them, and so if there's a resource in that area, she finds it. And if not, there's sometimes ways to work around it. It's not a magic wand, but it does. We do. Sarah, as our social worker on the team, does work hard to support resources, information to PCPs.
And
Can
I would
just
agree.
add on to the question about schools. Oh, what were you saying?
I was just going to say, Heidi had mentioned, you know, just being in Westminster area. It is, I mean, we're saturated in the metro area. We're still saturated with as many services, and there's still wait lists for ABA or other additional, doesn't have to be ABA, but psychology, etc., to be able to support these kids, because they do require additional support, as we all know. And so I can say it's the number of kids with autism, or people with autism, essentially, additionally, it grows, and the providers to be available, like we talked about, still doesn't grow as fast as that number. So yes, there's still an issue with getting services, but there are so many people out there, and we just have to keep up with each other and maintain the number of people that we can that can provide and understand autism as well.
I was also just going to add a little bit more about our partnership with schools. Heidi, you make a very good point. We really look forward to partnering more closely with schools. Part of our intake process that we've built is to ask families specifically for IEPs and IFSPs and for any other information from the school that they have. One of the challenges can be parents that either really don't want to share that with us because they feel like they want us to provide our opinion without school input, which I think is not best practice, but that's the way the parents oftentimes prefer it, or are really challenged to getting that IEP information to us and us getting the releases to talk with the schools. So it's something we recognize as an opportunity for improvement. We clearly want to partner with schools. In fact, we have board certified school psychologists on our staff who are very expert at managing school information, but we need to do a better job of it.
We actually have had some people from the schools want to do the echo, and we said, okay, you know, it really is geared to primary care providers, but we have had some school personnel participate in our echo as well.
And we frequently interact with school, either teachers or other special education providers. And, you know, especially now that the parents can't go into the school or really hang out on the playground, we've even done that more because obviously they're the ones who see how the kid interacts with peers now. Families don't have as much exposure to that because of social distancing. So I will tell you this though, teachers are harder to get in touch with than doctors because they're so busy and in class. And so sometimes it becomes a little bit of a struggle to do that. But most teachers are fabulous and actually will give you their cell phone number, you know, so that you can get in touch with them.
And any other questions in the chat that you think we should discuss, or if anybody wants to unmute their mic, please do.
Yeah, so I mean, there were some questions about what could PCPs do in their office. You know, obviously they're not going to be trained on an ADOS. As I understand it, and Sarah Maddie might want to pop in here, Medicaid only requires some type of an evaluation. And so if the primary care provider feels very strongly has ASD, then they can use some type of screening tool as their evaluation. And you don't have to have autism to get ABA services actually through Medicaid. You do have to make a case as far as behavioral concerns. But Sarah, I'll let you.
Yeah, and I think the question was related to more about diagnosing and if Medicaid will reimburse based on what you're utilizing. And so I think that is a question maybe for Ann and Sandy about what is Medicaid reimbursing on the diagnosis. But as far as services, Medicaid is not one of the insurances that requires an ADOS. Some private insurances do require additional outside of an ADOS, including an SRS or other screeners that are actually available. Not every insurance is actually requiring an ADOS. TRICARE is one to think about, but just so you're aware of, if you're doing a diagnosis, it's still possible.
You know, some states, I know Massachusetts, I have colleagues in Massachusetts, and they say they have to have an ADOS to refer them for behavioral services. That's not the case in Colorado. And, you know, and there are some, like I just saw somebody with TRICARE last week, and all they needed is a yearly Vineland and SRS, which is the social responsiveness scale. So, but they didn't need a big diagnostic assessment. You know, there's some kids who you could make the diagnosis of autism in the elevator. And so it's not just making a diagnosis. So it's knowing how to talk to the families, being able to access services, Some kids definitely need cognitive and adaptive skill assessments, but it's not one size fits all. And also sometimes just making the diagnosis, talking to the family, get them into services. And then if they need more of an assessment in other domains, we could do that as well. So we try to individualize it based on the child and the family's need, and what the primary care provider is most comfortable with.
And I will say that we have expanded our sleep and toileting clinics during COVID, but there are a ton of kids with those issues. Obviously, 50 to 80% of kids with developmental issues and ASD. And so I think that we're working on that, but we're also training the providers in ECHO on sleep issues, and this next iteration of our ECHO series will also address toileting because they can be huge issues for families.
And we cover med management for ADHD, anxiety, and we're going to be adding more like irritability and problematic behavior. And the PCPs really want more med management. And on our ECHO team, we have a doctor of pharmacy who works in the inpatient child psych unit for kids with dual diagnoses. And so, but she attends our trainings as well. So we have psychology, physicians, social work, pharmacy, genetic counselor. Am I missing it? We used to have a nurse who was a school nurse before she was doing that, but then during COVID, she had a shift where she was working. And sometimes like in one of the echoes, one of the cases, we were concerned about trauma. And so they wanted to know about trauma-informed care. So we had one of our psychologists with expertise in that area come and talk to that group. So we pull in experts based on the needs of our participants.
I just wanted to circle back to the screener question for what can be done in the PCP's office, because this is something that I think comes up when I've been out doing the PCN trainings as well, which I think is great, right? That the PCPs are enjoying the trainings and then they're asking, what else can we do, right? Can we have some additional resources in the office that we could use to kind of prep these kids further or to help us feel confident making the diagnosis? And so I think that also creates more opportunity for additional trainings. And part of what Anne was talking about before about the STAT training, right? These are options that are kind of advanced training options that we could continue to work on with our partners to say, okay, here's the STAT or here's the SRS. This is how you score it. This is how you interpret it, or other screeners that may be helpful in that. And I'm seeing another kind of comment in the chat too, that sometimes providers, because they are unfamiliar with other autism screening tools, will pull on the MChat, right? Which the MChat is the autism screening tool for kids who are 18 months, 24 months, that's supposed to be administered at those well-check visits. I've also gotten referrals or kids that show up in the chart that are 17 years old and the PCP sends an MChat, right? So that is not the appropriate use of an MChat, but it probably is a reflection of the fact that this PCP wanted to get some kind of documentation of social communication deficits, and this is really the only tool that they knew to use. So these are kind of opportunities for us to do advanced trainings in that area.
But at MChat, I actually just read something this morning that the MChat, there's something called the POSI, POSI, that has a little better sensitivity and specificity than the MChat are. So
yeah, this is something I hate to talk about, but the MChat is not a good tool. And I hate to be that crass about it because it is our tool and we need to be doing some kind of autism screener early on. And that's the one that we have right now. But there are recent studies that show One of the statistics that stood out to me was that only 40% of the people who are identified by the MChat as being in the kind of clinical range for autism go on to get an autism diagnosis, right? So we're missing lots and lots of kids, and not to mention the fact that there's a lot of disparity in minority groups, especially where there's kind of over pathologizing happening using
And to
that
do
tool.
the MChat properly, you're supposed to then do the interview. And that is supposed to make it a little bit more specific in terms of the diagnosis. And most people don't do the interview afterwards.
Yeah. So when I'm out working with PCPs, I say, do the MChat, yes, yes, yes. And also, you are a better tool than the MChat, right? And so if you really know kind of what these questions are asking, it helps you kind of use the MChat as a tool, which is what it's supposed to be used for. And then you can use your clinical gut and your clinical expertise to kind of take it all the way. But again, use the MChat. We have to use the MChat because it's the standard set by the American Academy of Pediatrics, and we want to stay in line with that. But I think we are always looking for tools that are more refined, that capture our kids more accurately.
Actually, the AAP, just to make it clear, they have more than one tool for autism screening. If you go on their website, it's not just the MChat. So that if you go on the American Academy of Pediatrics, they have validated screening tools for general development, and it's not just the ASQ. And they also have validated screening tools for autism, which is not just the MChat. But that's what we generally use. Just, I wanted to be, but you could go on the AAP website and all those tools are there.
So I think that most questions are asked. Does somebody want to chime in and
It looks like there's
if
one
we
more. If the PCP is not in, I guess, in agreement with the speech therapist, yes, still refer. And our questionnaire essentially will identify and then talk with the PCP as well, because every time we talk with a family, we send a letter to the PCP to notify them of the services. So if a speech therapist is internally, we have a process. If a speech therapist is concerned, they send a referral to us and we start the process with the questionnaire. So because there's always questions on there to ask in order to see the development, including developmental milestones, et cetera, of the family's reporting. So there could be other things going on that maybe they didn't say in the pediatrician's office.
yeah, and just to clarify too, when we use the word management, we mean managing not the child, the family, or autism. We mean managing the behaviors or medical comorbidities that are getting in the way of a good quality of life. So it's not about making autism go away, or it's about helping the family and child to have a better quality of life. Because we all need to manage something in our lives. I know I have several things I need to manage.
And I think there's just a continued question about services, and telehealth is great, but not really with toddlers. I totally agree. And it's been difficult for our younger kiddos to get out and be socializing with other people, and parents have noticed that. As a parent of a toddler myself, that is the same in our household. And it's so expansion, the biggest gaps, it's really hard to say what age groups. I think we see a big gap in the older age group as well, in the transition age, so transition to middle school and high school. So those age groups are also struggling as well, as far as being able to socialize. And when they're trying to transition to be an adult, what does that mean for them? And when they're not in school and practicing those skills, those are really hard. So social skills can be it's very difficult right now. Most social skills are actually via telehealth. So if we're thinking about gaps, that's one of them. And also being reimbursed by insurance. So if there's a lot of social skills out there that are not paid for by insurance, and so those programs would be essentially be great. We have one at Children's, but it's via telehealth.
And also, just to clarify too, when we talk about ABA, we talk about ABA as an overall model where you try a specific strategy and then look at your data to see if the targeted behavior or adaptive skill or communication skill is improving or decreasing depending on what you're looking for. And so we have recognized that, the old school ABA, as you could call it, or the discrete trial ABA. I don't know, Liz, do you want to talk about this more? It is something that
yeah, it's a complex topic. I think this is something we're navigating too, as an institution, because as I've been saying to a lot of our colleagues recently, but within the last 10 years, 10 years ago, I think there were a handful of ABA providers in Colorado. And now, Sarah, what is it, 125, something like that? So we have 125 different ABA agencies that are now here popping up over our region in Colorado. And of course, there's a part of me that just thinks this is wonderful, because the more people who are here to support our families with autism or developmental delay, the better. However, it does give us kind of quite the lift in terms of vetting different agencies and knowing kind of where the best quality therapy is coming from. But it's a complicated question that I think is akin to the same thing that you would ask for kids who have anxiety or for kids who have depression. A lot of time, the most powerful, and actually research has been done on this, the most powerful and kind of telling variable in terms of whether therapy is effective is the match between the therapist and the client or the patient. And I think that there's a lot that's true about this that is true for ABA as well. The approach, applied behavior analysis, and I was an ABA therapist for years before getting my doctorate. The science of applied behavior analysis is something that all of us as kind of specialists in this area are familiar with and endorse. I think the application and implementation of ABA needs to be thoughtful, intentional, and personalized to the child. And so I think a lot of our work with families is to help them understand what they should be looking for when they're partnering with an ABA provider, and helping families feel empowered that they can ask questions about, so what are we working on here? And how do I know when this goal is met, or things like that, so that they can be discerning about whether they are, happy with the quality of service that they're getting. Because I don't think it will be possible for us to keep track of 125, 150, 200 agencies, and have a running list on what's good and what's not. But I think we can empower families and other providers in other disciplines to help families know how to kind of check in themselves about what services their children are involved in.
And just building on that, Liz, so if you take away anything from this webinar, we hope you will take away our dedicated passion to kids with autism and developmental disabilities, but mostly our dedicated passion to partnering. And no care, no assessment, no system is effective if we don't partner and work as a team with the family, with the schools, with primary care, with therapists. And that's the very best work we can do. Autism has changed significantly over the course of our careers, and we want to change with it.
So,
May I
okay,
ask a double click on that question? I really appreciate the response from everybody, Liz and Sarah and Rebecca. But as a provider of what we hope are very high quality ABA services, servicing in the Denver metro area, we are committed to Colorado. We see, the hyper growth of ABA services, a lot of out-of-state providers jumping in, and some are high quality, some are not. I understand the concern there. We're thinking about where geographically we might expand to next to help serve the underserved populations that we try to help. And as you're touching on rural and frontier topics, do you see geographic holes in particular for younger kids who are in need of these services? Thank you.
Definitely. I would say the areas actually that when Richard had shown were not touched in the ECHO series, and it would be the northeastern and the eastern slope, or the northwestern and the eastern slopes. They don't, it is very difficult for us to find providers for those kiddos, and we do see quite a few. And even there's some popping up in the southwest corner. There's some popping up in the southeast corners, Trinidad, but it's one. So if we want to think about, we don't technically have a true number of the areas of how many kids are diagnosed in that area. I don't know where that number can come from, but essentially, probably from the CCBs actually, if you wanted to review with them, but we don't have that number, but that's where I can say it's very difficult for us to find.
Thank you,
services.
Sarah. I actually want to be mindful of time. We're like a minute over the end of our webinar. And so I really want to thank everybody for participating and providing great questions. And you could contact any of us with additional questions. And it really has been a pleasure to be able to present all this that we're doing to you. So thank you very much. And hopefully we'll see you again next year or sooner. So thank you guys. Bye.